by doing a few testing and clinical characteristics of the patient, I'm hopeful that by the end of this lecture or presentation, you have a better feel of what can be some next steps to do that can be done locally, so then the patient can get adequate care locally, because at the end of the day, not every patient with pulmonary hypertension needs to come to Morgantown to be looked at. A lot of this can be figured out by their clinical history, their echocardiogram, and a few other things that we'll talk about to get them on the right track. Next slide, please. So, you know, pulmonary hypertension is a hodgepodge of many different things, and it really is a diagnosis that you just kind of go through a checklist and kind of mark things off that you work up and rule out. And based on the WHO, which is the World Health Organization classification system we've used, it's going to be updated more next pretty soon, but basically there's 5 different main types of pulmonary hypertension. All of them but group 2 are pre-capillary, meaning before the lungs. Group 2 is post-capillary. And in group 2 and group 3 are the most common. So basically what I try to do is rule out group 2 and 3 first before I get to the other ones. If I have a good idea about group 2 or 3, then I kind of I get to the diagnosis and be done with it. So group 1 is pulmonary arterial hypertension. That is truly the zebra. This is the ones that should get referred to us. These are the ones that are treated with medications. Very rare incidence, though, very small population. Those are truly the zebras. The rest are kind of the horses of the pack. Group 2 is the most common, which represents about 2/3 of the population, 2/3 of the pulmonary hypertension. And those are the left-sided heart disease ones, aortic stenosis, mitral regurgitation, HFpEF, HFrEF, all those different types of left-sided heart physiologies. And then group 3 is a chronic hypoxemia. Those are the lung disease alphabet soup. Those are the ILD, OSA, COPD, IPFs, and so forth. Those are all, and group 3, especially in the state of West Virginia, very common. I see a lot of coal miners' pneumoconiosis. I see a lot of emphysema, a lot of COPD, a lot of smoking, tobacco, a lot of sleep apnea. So group 3 is a big component of the state of West Virginia. Group 4 is thromboembolic. That's the ones that are called CTEPH, chronic thromboembolic pulmonary hypertension. Those are ones with a history sometimes of DVTs and PEs. And then they get treated, but then after treatment, they're still short of breath or symptomatic. Those are basically ones that the PEs haven't resolved. The pulmonary arteries have remodeled, and they develop pulmonary hypertension from it. And lastly, group 5 is kind of the alphabet soup of everything, kind of the leftovers, sarcoid, dialysis, sicklers, all the miscellaneous ones that don't fit nicely in group 1 through 4 are placed in 5. The most common group 5 one truly in West Virginia is dialysis patients. That's by far the most common. The rest I can usually put them in another bin per se. Next, please advance. So group 1, like I said, very, very rare. So group 1, it's about 15 per million. And if you look at the U.S. population of 320 million, the estimated number of cases of PAH in the U.S. is about 4,700, and total less than 200,000 in the U.S. So group 1 is very, very rare. So for you guys, you should be able to knock out the rest, you know, look at and get to the right diagnosis on the other ones. And then the ones that meet group 1, those are the ones truly that should be referred to a tertiary center, because this is a very rare disease, very orphan, and meds need to be used, which a really expert in that should be treating that. So although pulmonary hypertension is not rare, group 1 PH is a very rare disease. And as I said, pulmonary hypertension is not. Next slide. Here's an example of an echo study. This was done in Australia. It was a single echo lab with an Australian community of 165,000. And they saw pH on the echo. So this is you know, a significant amount of echoes. It was 936 echoes that met the criteria. And of those 936, they had a sufficient tricuspid regurg jet and had a PH systolic pressure on echo greater than 40. So not just minimal pulmonary hypertension, kind of mild to moderate and on up pulmonary hypertension. So in those cohort, they said, okay, let's figure out all what the group of PH they meet. And when they did that, and not surprisingly, the majority of patients with pulmonary hypertension on echo, 2/3, were due to left side heart disease. So once again, when I see a patient on echo with pulmonary hypertension, I try to say, what can I do to rule out left-sided heart disease? When I do that, most of the time they fall into left-sided heart disease. And so then I'm done with the workup. I know it's left-sided heart disease and I move on. That's 2/3 of patients. And then probably in West Virginia, that number is probably about 60%, because what really is predominant is the lung disease. So probably about 25% of the PH we see in the state is the lung disease, COPD, OSA, ILD, IPF, and so forth fit into that category. And then once again, very small percentage are your CTEPH and PAHs. So that's like 3 to 5% of the whole pie is that. So really, once again, if you can rule out left-sided heart disease or rule it in, or rule out lung disease or rule it in, you've done 85% of your job by doing that. So that's why it's super important to do your best to say, okay, do they have left-sided heart disease or do they have lung disease? Because you do that, you feel pretty comfortable with, doing some maneuvers to help treat that. Next slide. So looking at pulmonary hypertension, kind of the view of a PH clinic. So not to only look at echo, clinical characteristics really tell me which way to go in these patients, because that tells you the story. A 90-year-old with, blood pressure of 180 with pulmonary hypertension on echo, they're probably going to have left-side heart disease. Where a 30-year-old with scleroderma history with severe PH on echo is probably going to have group 1. So the clinical characteristics of the patient really is important. Getting a good history of the patient is utmost important when evaluating these patients. Next slide. So you have two patients. We have Jane and Sarah. And with Jane and Sarah, Jane is a 32-year-old without not much significant past medical history. She's had dyspnea for about 3 years. And a lot of times these patients get treated for asthma and depression, and especially asthma, because that's very common. And eventually an echo was done, normal left ventricle size and function. RAE stands for right atrial enlargement, RV enlargement, and an estimated RVSP of 80. That's one patient. And you have Sarah. She's a 76-year-old lady with hypertension, diabetes, and morbid obesity. She also has had shortness of breath for 3 years. And her echo shows an RVSP of 80 as well, but she has an echo that demonstrates concentric left ventricular hypertrophy, normal LV function, but she has left atrial enlargement and also the right atrial enlargement and right RV enlargement. So although both have significant pulmonary hypertension on echo, the morphologies on their echoes that we'll review are different, and also their basically history. One's 32 years old and one's 76 with a lot of HFpEF risk factors. So we'll dive in that in just a moment. Next slide. So distinguishing PAH from HFpEF. So they're looking at a database population. There was 500 patients with true primary PAH, which meant a mean PA greater than 25 and a wedge less than 12. And then you had one population that was 100 of PH HFpEF, which really just means, that they have heart failure, preserved EF, but significant pulmonary hypertension and some pulmonary vascular resistance. So PVR is a marker of just resistance in the lungs. And those patients were greater than 2.5 Wood units and a transpulmonary gradient greater than 12. So really, and then 45 HFpEFs. And basically what you really want to take from that is 3 different patient populations. One, the group 1 PH that we just talked about, but then the PH HFpEF and the HFpEF patients, the main difference about that is the patients with PH HFpEF have much more significant PH. It is still due to left-sided heart disease, but there's some resistance in that pulmonary circuit. Those people have a worse prognosis. And they looked at these patients, looking at clinical, echo, and hemodynamic parameters were compared. So 3 different cohort populations. Next slide. And what you saw, I bolded the ones in red that really tell you what kind of characterizes them, okay? So patients that had HFpEF or PH HFpEF tend to be older. They were 64 and 67 years old. And the ones with pulmonary arterial hypertension, the group 1s, they were younger. Average age is 48. Very big female predominance. You guys can see, especially in the PH subtypes, the PAH and the PH HFpEFs. So definitely more because of probably the remodeling that occurs because of hormones and those kind of things. Women tend to get predisposed more to pulmonary hypertension than males do. The other thing was hypertension. More hypertension in HFpEFs and PH HFpEF. So once again, left-side heart disease is what it screams. Diabetes. More people with PH HFpEF and HFpEF tend to have diabetes. Same thing with PH HFpEF and HFpEF. More obesity. More coronary disease. So really, when I think of a young patient that doesn't have these risk factors, I think of more group 1. Patients that are more elderly, female, obese, diabetic, hypertensive, all those kind of risk factors tend to have more of the left-sided heart disease. So it makes a big difference, and that's where getting a good history and knowing your patient is utmost important in kind of teasing through all this. It's really kind of detective work on figuring this out. So really the clinical characteristics is the driver. They all have shorter breath. So functional class, they're all 3 and 4. Shortness of breath severity does not dictate that. So they're all shorter breath. Next slide. Not only do you see a clinical characteristics, the echo characteristics as well. When you see patients with concentric left ventricular hypertrophy, those tend to be the HFpEFers. The ones that have left atrial enlargement, HFpEFers. The ones with predominant right atrial enlargement, RVH, you think of more PAH. So those are really kind of the characters. We look at the echo and their clinical characteristics, and we'll get to a little slide that shows the video of the echoes, really the morphology of the echo. But for you guys, when you're looking at an echo report, look, is there any evidence of left ventricular hypertrophy? That should always be stated. You know, there's mention of diastolic dysfunction. Those are all important things. And then looking at the left atrial size, is it enlarged or not? Is it normal? The right atria. So if you have a huge right atria and a small left atrium, the pathology is probably kind of group 1 physiology or, you know, lung disease, because they both will look similar. Next slide. So when you look at these, this is kind of a summary slide of and some of the hemodynamic data that you see. Really, HFpEFers don't have much pulmonary hypertension. It's just diastolic dysfunction. But PAH have markedly elevated mean PA pressures, can have elevated RA pressures. So if you look, the PAH and PH HFpEF could be similar, but the big things are their age. PH HFpEFers tend to be older. PH HFpEFers tend to be more frequent comorbidities. PH HFpEFers tend to have less issues on the right side in terms of right atrial enlargement and RVH. And PH HFpEFers tend to have more left-sided stuff like left atrial enlargement and left ventricular hypertrophy and so forth. So that's kind of a summary side of what you'll typically see between the differences. So it's super important to try and tell the difference to at least identify if someone has that left-sided heart disease phenotype. Next slide. Echo, not only is echo and clinical story important, electrocardiogram super important too. Simple things you can do in the clinic. Get an EKG. Is there evidence of RV strain? Any evidence of RV hypertrophy, right atrial enlargement, and so forth? So those are all big characteristic findings, and a lot of them you can get 80% of the time just by EKG, for PAH. So it's not sensitive enough to be a screening tool, but very common. You'll see this case where you'll get an EKG like, oh my gosh, they're having chest pain and it must be a coronary event. Actually, it's not. Chest pain is very common in severe PH, and their EKG can be markedly abnormal. So EKG is very important in the workup as well. Next slide. And that EKG will look markedly different compared to a HFpEF patient. So echo, very important. Here's an example of someone with group 1 PH. As you can see, the enlarged chambers on an echo, that's the right side of the heart. They're very enlarged, the right atrium and the right ventricle are ginormous. The PA systolic pressure, we either a little calculation to get to that, but this echo still frame shows RV hypertrophy, a flattened septum, and look at how the LV size is. Typically, the LV should be bigger than the right, and the left atrium is small compared to the right. And a lot of times on echo, if there's a pericardial fusion, that can be a sign that that's due to group 1 PH, but not always. But it's once again, it's little pieces of the puzzle that you're putting together. So as you can see, the right side of the heart is what sticks out in this echo. Next slide. The sensitivity of that is about 80%. Oh, yeah, you can go ahead. So really, echo is a great workhorse. Here's an example. Step 1, you look at when you have the images, you can look. The one on the left is pulmonary venous hypertension or HFpEFers. You can see the apex is kind of left dominant, and the left atrium below that red is ginormous, where in contrast, PAH, it's the opposite. That right ventricle is apex forming, we call it, and the right ventricle is much bigger than the left. The blue is the right ventricle and the red is the left ventricle. So much different echocardiograms that we see on that. Next slide. Here you should be able to, click through, and then on the one more, you should be able to click on each picture, and there'll be a video. If you can get those playing, please. Or will it play? There you go. Great. So as it's loading there, give it a second. The one on the left is pulmonary venous hypertension. The left side's not phased by the right. It's it's very round shaped, like basically a circle. And it's called, it's like a donut. Where on the right, you can see that ventricle, the left ventricle, is called D-shaped. And it looks like a D. And what happens is the right side of the heart is ginormous on the top side of the screen, and it's really affecting the left side of the heart. And this is what looks like of a patient with pulmonary arterial hypertension. So basically, looking at the echo pictures and the description, you have a general sense of where the pulmonary hypertension is coming from. But they definitely have distinct different phenotypes on echocardiogram that helps us guide us. Next slide. So once again, you don't have to know what these pictures look like, but the diastolic dysfunction shows that on the left. And on the right, this is called an abnormal relaxation pattern. That's what you typically see with pulmonary arterial hypertension. On the left, you usually see kind of a restrictive failing pattern. Once again, if you hear something that says diastolic dysfunction, you got to think of more left-sided heart disease. And so that's another thing we look at on the echo is that transmicral Doppler. But on the report, I don't expect you guys to know the images, but look on the report to see if they say any evidence of diastolic dysfunction. So next slide. So kind of the diagnostic workup that's, I think, important for you guys is, you look at a patient, and is there a reason to suspect PAH? Clinical history, exam, chest X-ray, CT chest cells, pulmonary, dilated pulmonary artery, the EKG shows some maybe evidence of pulmonary hypertension. So if there's no reason to suspect pulmonary hypertension, no further evaluation obviously is necessary. Well, if there is pulmonary hypertension likely? Well, get an echo. And with echo, we measure the RVSP, evidence of RV enlargement, right atrial enlargement, RV dysfunction, and so forth. So we really try to look at what's going on the echo, and we measure those things. When we do that, then we try to help decide, is that pulmonary hypertension due to left side heart disease? That's where the echo is very helpful. It is, then we, treat the underlying disorder. Do they have LV systolic dysfunction? We give them meds, Entresto or co-reg, beta blockers, and so forth. Or do they have HFpEF where they need some, Lasix to help with that? Next. Is the pulmonary arterial hypertension due to congenital heart disease? We do an echo with contrast. Sometimes we do a cardiac MRI, but once again, the echo is very helpful in knowing if it's due to congenital heart disease. If it is, you have them see a pediatric cardiologist or an adult congenital cardiologist to help manage the treatment of congenital heart disease. So that's very important as well. Next slide. If you're thinking pulmonary arterial hypertension, you're welcome to do this, or we do this in our clinic, but if you're really worried about group 1 pH, we check HIV, we check ANA, and so we check hepatitis, we check those basic serologies. And if those are positive, that makes you think more group 1. You check, so there's a plethora of different tests you can check. I don't expect you guys to have to check these, because those can be done at our center, or any other center. You're welcome to check them. But these are important to tell you what type of group 1 they have. So if you think that's the cause of it, then checking it is certainly okay to do. And treating those underlying disorders is what's helpful. And a lot of times these patients need pulmonary hypertension meds. Next slide. If you're worried about chronic PE, then you get a VQ scan. And if there is chronic PE, then getting a pulmonary angiogram or CT, and then you refer them for evaluation for surgery. So that's really important as well. Or is it not PE, or you're thinking of chronic lung disease? PFTs, ABGs, and CT chest are very important in these patients as well. A common mistake is made is, they have asthma, but you never had PFTs. So you really got to get those, because sometimes it's not asthma, but instead it's severe PAH. Now, obviously, next slide. Obviously, sleep study is super important for pulmonary hypertension workup. It's even part of the guidelines. If pulmonary hypertension is seen on an echo, it's not a bad idea to get a sleep study on them. If I had to pick magic test for you guys to order, if I saw pulmonary hypertension, I would say, okay, do they have left-side heart disease? And if they have a lot of that, treat that. But if they don't, looking at the lungs, so pulmonary function tests would be good, and even a baseline chest x-ray and an ABG. I think those are reasonable. And then the sleep study. If those are ruled out, then getting a VQ scan after that. And then after all that's been ruled out, referring them to someone like us, or having a conversation with an expert over the phone would be a reasonable approach too, to say what are the next steps. But a lot of this, it can be done locally. If they have significant lung disease, sending them to a pulmonologist and helping manage it as well would be important. But really, if you rule out left side heart disease and left side heart disease and lung disease, you've taken 85% of the burden of the diagnosis taken away. And I think that can be done definitely locally. Next slide. So back to our patients. They had a right heart cath, both of them. Both had high RA pressures. Both had high PA pressures. But if you look, Sarah, which was the older, morbidly obese patient with diabetes and hypertension, her LVDP was high, so a lot of left side heart disease. Both of them had pulmonary hypertension. Both had reduced cardiac outputs. Just Jane on the left truly had group 1 pH, because her LVDP, which is like a wedge, was less than 15. So she fits the group 1 picture. And that's really what you need a right heart cath for, really to define, do they have group 1 disease? So once again, patients were similar, but at the end of the day, much different physiologies. Sarah's problems on the left, Jane problems on the right. Next slide. And thank you, and be open to questions and comments. I wasn't gonna, if we can do this one, but I thought I'd leave the forum open for questions first.
Thank you so much for that. Yeah, if anyone has any questions or comments about that didactic. You're more than welcome to chat us as well, and we can read off any questions if your mic isn't working or something.
I think really the take-home point: do your best to rule out group 2 and 3, which is left-sided heart disease and lung disease. I think the sleep study is super important. PFT is super important. Please don't give someone a COPD diagnosis without getting the proper PFT. So I see that a lot of times, unfortunately, and that gets thrown into chart lore, I call it, where a couple people say they have COPD just because they're short of breath and maybe need some oxygen, and then that gets passed on through their chart without an official eval. So I think that's really an important thing that's very helpful in these patients. So we'll briefly, I'll cover just a very rare, a case that happened to me a while back, but it's a little different type that's not your bread and butter pulmonary hypertension case. So I'll just kind of give you a different flavor of what you can see with this. And this is not something I'm expecting you guys to know or diagnose, but just an interesting case that helps you keep you on your toes.
Would you like me to advance the slides?
Yeah, yes, please.
Okay.
So we got a 39-year-old that was referred from Pulmonary for evaluation for shortness of breath and dyspnea. Next slide. She's got morbid obesity, a BMI of 50, hypertension, no sleep apnea though. She has restrictive lung disease due to her obesity. She has APLAS, which is antiphospholipid antibody syndrome. She's had 2 pulmonary embolisms and has a history of psoriatic arthritis. So just by history, there's some flags. She's 39, so she's younger, but also she has some markers, hypertension, morbid obesity, that kind of puts her towards left side heart disease, but then she has also recurrent PE. So I think of chronic PEs as well as a cause. Next slide. So she had a PE in 2006, and at that time, her INR was 2 and 3 and was on room air. But then she had a repeat PE in 2012 with despite a therapeutic INR. Now they're running her INR 3 to 4, and now she's on oxygen, 2 to 3 liters, and she's had progressive shortness of breath, now tachycardic regarding beta blocker, and then because she was short of breath, they treat her as asthma, but she was dizzy with exertion and chest pain, which doesn't really go along with asthma. And the mother has APLAS as well. Next slide. We walk her and she desaturates. So this is real deal. So this is not like asthma. HFpEFers shouldn't really do that either. So she has significant hypoxia. So I'm thinking about lung disease, and I'm also thinking about CTEPH because chronic thromboembolic pH, because the amount of oxygen she requires, I think of more lung pathophysiology. When you do the echo, she has a normal LV, and RV is not well seen. And she has a normal IVC, and we did cardiac MRI. The RV was normal. So, it was a little bit puzzling, but we moved on. Next slide. So what's the next step? These are different things you can consider. RV is normal, but she's hypoxic. We still got to figure out why. Shortness of breath and asthma, refer to pulmonary, they referred it to me, so that wasn't the right answer. Lasix, probably not a good idea. Her IVC was normal, and this is hypoxia, not pulmonary edema as a cause. Right heart cath or a VQ scan. So right heart cath and VQ scan are both reasonable things. You want to see, and PFTs are super important as well in the workup of this patient. Next slide. So we did a right heart cath. Her mean PA pressure is 28. She had a normal RA pressure, normal wedge. So no real significant pulmonary hypertension of this cause. But once again, she was so hypoxic. So we knew that pulmonary hypertension wasn't the root cause of this, but maybe PEs could be. So next slide. We continued on. Next slide. So we did a VQ scan. And here's an example of the ventilation portion of the VQ scan. And as you can see on the far left picture, the ventilation is pretty homogeneous, meaning she's getting enough air to the lungs. So ventilation's good. So that's a good sign. Now let's go to the next slide. Now this is the perfusion, and what we call this is like a moth-eaten appearance. So this is very abnormal. This is the perfusion scan. So she's getting air to those lungs. However, she's not getting the blood flow to those areas. So that suggests she has chronic pulmonary embolism problems. And what's happening is she's getting hypoxic because she's breathing in air, and then that air is not getting, she's not getting oxygen because those areas are malperfused. So basically she's working with parts of lungs that aren't working because of the blockages, and that's what's causing the hypoxia. So this was a very markedly abnormal VQ scan, and despite being on Coumadin. We like to see patients on Coumadin for 3 to 6 months before we give this diagnosis, because in acute PE, a VQ scan will look like this, but should normalize within 3 to 6 months. So if someone's symptomatic after a PE 3 to 6 months later, it's not a bad idea to repeat a VQ scan to see if there's any residual PE, because that's what will happen. It's not the pulmonary hypertension that's making her hypoxic, it's actually the dead space ventilation that's occurring. Next slide. So we did a pulmonary angiogram, and then you can see the upper right lobe of the right lung is quite perfused, but the lower part's not. So that is consistent with lung clot. Next slide. And that's not acute lung clot, that's chronic remodeling. So it's not like, oh my gosh, blood thinners will fix it. No. So we referred her for surgery. She got out the parts of the pulmonary artery where it had that chronic remodeling done, and that was taken care of, and now she's post-op, no longer requiring oxygen. So here's kind of a case of where getting to the diagnosis is super important in managing these patients. I think that was and we'll stop there.
Thank you for that example case. That was really excellent. We appreciate it. So did anyone have any comments about that, the case that Dr. Takamo just presented to us? Or questions?
Hi, Dr. Takamo. I had a question, kind of going back a little bit to your didactic, which was super helpful and we really appreciate it. So when you're doing sleep studies or looking for sleep apnea, what are you looking for specifically to either rule them into groups 2 and 3 or rule them out of group 1? I know you said it.
So basically you're trying to see if they have group 3 disease, which is sleep apnea. And that's when you do the overnight sleep study and see if they have any marked sleep apnea. If you do, you treat them and then wait down the road to see if they have any residual, if they have improvement in their symptoms, their echo improves, and so forth. But certainly you never consider them a group 1 if they have untreated pulmonary hypertension untreated sleep apnea. I've had patients that markedly obese, BMI 60 to 70, where their pulmonary hypertension PA pressures were 80, 100. And then when we get them treated on sleep apnea, they markedly improve. So always ruling out group 2 and 3 is key before you even get to thinking about group 1. And as part of the criteria for group 1, you have to rule out sleep apnea on that.
That's great, thank you. And so when you do treat them for the sleep apnea, you see improvement, and how soon should you expect to?
That's more kind of a months kind of thing, usually about 3 months. And as long as they're compliant, if they're not compliant, you'll see no improvement. But definitely if they're compliant with it, you should see some improvement with it.
Okay, excellent, thank you.
So would you repeat that echo in as short of a time period as 3 months after they've initiated their CPAP therapy, or?
I say 3 to 6 months. I leave it up to the clinician. If they're markedly better, you can just make that decision then. I'd repeat it sooner if they're getting worse or not doing well. So I kind of leave it at that point. But certainly Some patients will still, despite even getting treated with sleep apnea, you might see some improvement. You might not even see any improvement at all, but definitely depending on their clinical characteristics, kind of will decide what the next steps are. But you should see some improvement on the echo after, certainly 3 to 6 months, 6 months for sure.
Dr. Kakamo, just one more question, and I know this is silly, but just to make sure about what we're looking for. But what complaints are, when they come into the clinic, what complaints should we be really listening for?
So unfortunately with pulmonary hypertension, it's shortness of breath, and that's like everything. So it's really, clinical characteristics. They're short of breath, so you get an echo. And once you get the echo, you see the report with pulmonary hypertension. That's really the 99% of the time of how a primary physician or internal medicine or whoever is going to get that diagnosed with pulmonary hypertension is through echo. They're not going to go see him and say, I think you have PH. They're going to say you're short of breath, I'm going to get an echo. I mean, that's what we do. Another sign is they get PFTs, and they have a pretty good PFTs, but they have a markedly reduced DLCO. That's sometimes a symptom of pulmonary hypertension. So those are kind of the big ones, but definitely echo and EKG are probably the big ones to catch. EKG for PAH group 1, but in general, all of pulmonary hypertension, it's echo.
Awesome, thank you.
Well, thank you, guys.
Thank you. Were there any other questions or comments? We do have about 15 minutes left. If you did have further questions or comments you think of later on, you can absolutely shoot us an email, and we'll make sure to send that back to Dr. Kakamo to have it addressed. So wanted to ask everyone if you had any final words or comments. All right. Well, thank you so much, Dr. Kakamo. We really appreciate it, and that excellent example case you had prepared as well. So we really do appreciate you. Just a quick announcement. So our next session will be on March 6th, and Dr. Sokos will be providing our didactic on ejection fraction. What does this mean for you? So keep an eye out for that. We'll be sending out a recap email. And again, if you think of any questions or comments later on, just shoot us an email. So thank you all so much for joining, and we'll see you guys next time.
Thank you.
Thank you.
It's great to see you all. Thanks.